Hello, I never imagined I'd be standing right here one day talking about bowel cancer. But then I never imagined my dad would die from it. I'm Victoria Graham and I'm incredibly passionate about lifting the lid on a disease that so many people feel embarrassed to talk about. So what exactly is bowel cancer? Well, I spoke to Chairman of Bowel Cancer West, Mark Coleman.
Bowel cancer is a growth on the bowel. Imagine a very nasty mushroom growing inside your colon or bowel, which can then break off and go through your bloodstream to other parts of the body after it's developed in the bowel.
So the bowel is a generic term for what doctors would often call either the gut or the gastrointestinal tract. It is that portion of your body which helps digest and absorb the nutrients from food. There are two types of bowel, small bowel and large bowel, and it's the large bowel that is usually affected by cancer. Large bowel we tend to consider as comprising of two main parts, the colon and then the rectum. The rectum is the last 6 inches or so of bowel, and it is the bit which acts as a reservoir where you store the poo before you defecate. And defecation is controlled by a muscle at the end called the anus.
This is a plastic model of the colon that shows different diseases or pathologies affecting the bowel. And what you can see here is the lower part, which is the anus and the rectum. And this is the colon going all around the abdomen to the beginning of the colon, at which you see the appendix, in this case affected by appendicitis. And you can see other pathologies in the bowel, such as diverticular disease. These are diverticulae with a thickening and the pockets. And also you can see a growth on the bowel just here, which is a representation of bowel cancer. And you can also see some little polyps in the bowel as well. Bowel cancer most often presents with things like change in your bowel habit and bleeding from the bowel, sometimes with abdominal pain and sometimes with weight loss.
Do you think that patients are embarrassed by going to the doctor about this?
Yes, in fact, Bowel Cancer West has done repeated surveys of people's attitudes towards bowel cancer and the symptoms of bowel cancer. And what we've found is that particular groups of patients, particularly middle-aged men, are embarrassed about talking about the symptoms that they have, such as change in their bowels and bleeding, both to their partners and family and also to their GPs. And this is a real issue, and we want to encourage everybody in society not to be embarrassed about things like poo and symptoms such as change in bowel habit and bleeding. The first thing is to get over that threshold and go and see your GP if you think you have a problem with your bowels of any kind. And then the GP has a mechanism known as the 2-week wait referral service, where once they've been referred on to the hospital, they will be seen or spoken to over the telephone within 2 weeks, and if necessary, then investigations such as colonoscopy will be organised.
So this is a standard colonoscope, and it's a very, as you can see, flexible tube with a nice flashing light on the end. The bowel is not well lit, we have to do that. And you can control the tip of the scope just using the dials at the top, which will move it right or left. You can also control it by twisting the scope, and so you can insert it into the bowel, pass it round the bowel and have a good look at the lining of the bowel all at the same time. It's not something you want as a birthday present, but it's not a painful procedure. There's various things we can do, and patients are different. So some patients are very happy and very comfortable having no sedation at all. Some patients just need a little bit of gas and air. Some people would like to have some sedation. I think it's important to say sedation isn't an anaesthetic. You're not unconscious, but I would equate it to popping into the pub on the way to the endoscopy department and having one too many to drink. It's that sort of feeling of being nicely relaxed. You will get a little bit of bloating because we need to put air into the bowel to open the bowel up, both to see where I want to go and also to examine the lining of the bowel very carefully, and that gives people a trapped wind feeling. And that can be a little bit worse going around corners, but generally when you're around the corner you can take the gas out again and people are okay.
Sometimes instead of colonoscopy, if there are reasons that a patient can't have a colonoscopy or doesn't want it, we can use what's called a CT colonogram instead, which is a different way of imaging the bowel. Once patients are unfortunately diagnosed with bowel cancer, we use investigations like CT and magnetic resonance scans, or MRIs, to what we call stage the bowel cancer to see what it looks like locally and see if it's spread to other parts of the body.
So what we're looking for is anything that could be abnormal, and a lot of that depends upon the context of the patient. So if a patient's been sent in because of a bowel cancer screening test, you're looking for things like polyps or sometimes cancers. If patients have been sent in for specific symptoms like anemia or diarrhea, you're going to be looking for things like inflammation or little abnormal blood vessels, but essentially it's anything that doesn't look normal.
You mentioned a polyp. What exactly is a polyp?
So a polyp is a little bit like a warty growth in the bowel, and broadly speaking there's two shapes to them. We have what are called pedunculated polyps. They look like mushrooms, so there's a stalk with a head on the end of it. And then there are what we call sessile polyps, which are flatter things. They're a bit like a pancake or a cowpat, if you like. And they tend to be flatter and sometimes a little bit larger. And those we're particularly interested in the context of bowel cancer, because we know most cancers start off life as a harmless small polyp. And over a period of usually years, we think, they get gradually bigger, and some, but not all, turn cancerous. So because you've got a polyp doesn't mean you've got cancer, but there's a risk that some of them could turn cancerous. And so we think if we take them off at an early stage, we could be preventing things in the future.
How do you take them off?
There are various different ways of doing it, and it depends upon the size and shape of the polyp. But essentially we have metal snares which fit down the scope, down the channel in the scope here. And we can put the snare over the polyp and use a special electric current called diathermy to cauterize it and take it off. And then we retrieve it and send it to lab for examination.
One of those laboratories is here at the Royal Devon and Exeter Hospital in the appropriately named RILD building, where biopsies and blood samples are examined. Bowel Cancer West supports much of the equipment and scientific investigation here. Frank McDermott is a consultant colorectal surgeon and leading academic in the Royal Devon and Exeter Foundation Trust.
Screening is really important because what we're trying to do is diagnose cancers at an earlier stage, because if we can treat them at an earlier stage, patients will have better outcomes. So screening really helps us do that. And that technology again is improving over time. So we've now moved towards FIT testing from the FOB testing we used to do before, as we found that is more sensitive. And that allows us also to identify patients who have polyps, because if we can remove polyps before they become cancers, again, that reduces your risk of developing a worse cancer that might have a worse prognosis.
Screening is a process where you want to test the entire population at a certain age to see if there's an increased likelihood that they may have polyps in the bowel, which are a precursor for cancer, or cancer itself.
The research that I'm doing at the moment is trying to identify new biomarkers in blood, so that maybe in the future, rather than having a small poo sample that we're looking at, we'll be actually looking at blood samples in patients to see if we can identify any possible risk of colorectal cancer and then investigate those patients more aggressively.
Bowel Cancer West operates throughout the whole of the West Country, including Cardiff, Bristol and Truro. How long have you been raising funds?
Bowel Cancer West is a charity that is now exactly 10 years old. And we started in 2009 with the purpose of supporting research, training and awareness projects concerned with bowel cancer, because we perceived that there was a gap in the West Country in that particular area.
Bowel Cancer West have actually supported several of our studies over the years, and we're doing some very interesting research in rectal cancer, so looking into the rectal cancer to work out why they're unique and how different treatments for some patients may respond and others may not. One of my colleagues, Dr. DeBeese, was looking at the rectal cancer tissue itself, and we're looking at something called epigenetics. Epigenetics are looking at small marks on your DNA. So your DNA is the code that's passed on to you by your parents and contains 3 billion bits of information. But beyond that, there are little marks on the DNA that tell the DNA whether to make new proteins, for example. And that's your epigenetics. And that's the thing that's changed by aging, diet, environment, smoking, etc. And people talk about things like processed meat and what that might mean in terms of your risk of colorectal cancer.
Without sponsorship, we wouldn't have been able to do this project. I would not have been able to do this particular project. The funds that were given to us by Bowel Cancer West facilitated the equipment, the time of the lab, our ability to process the tissue and do the analysis and actually come up with answers that, without that sponsorship, we wouldn't have been able to have. Our research looked at the difference between tissues from patients with rectal cancer, the difference between their tumor tissue and normal tissue that doesn't have cancer in it. And we zoomed in on the genes of those tissues, and we tried to look at the switches that turn those genes on and off. As in every patient, there are switches that can activate the genes that cause cancer or the genes that stop cancer. And that's what my research looked at.
There's a lot of research going on in bowel cancer, and that's improving how we do things. We're trying to develop personalised medicine so that we can be a lot more personalised in our approach in terms of the tests that we do and the treatments that we offer. So I would advise patients to say that things are improving, and we have, I think, a much more holistic approach to how we approach medicine. So for patients who might need stomas, for example, we have stoma teams, we have colorectal nurse specialists who will help people through the process, and we're developing newer technology in terms of the surgical approaches that we use, things like laparoscopic surgery, robotic surgery, and lots of other different tools that I use in my day-to-day practice.
Apart from surgery, bowel cancer is also treated using chemotherapy and radiotherapy. I talked to Dr. Ian Fraser, a clinical oncologist at the Royal Devon and Exeter Hospital.
My role is that I give patients with bowel cancer chemotherapy and radiotherapy treatments, often alongside surgery, and sometimes as their only treatment, either to improve their chances of being cured of cancer or to manage their symptoms and prolong their life. We group bowel cancer into 4 stages, stage 1 and 2 being early stage disease that's managed predominantly by surgery. Stage 3 is locally advanced, where tumours are involving lymph nodes nearby, and those patients will often need chemotherapy and possibly radiotherapy as well as surgery. And then stage 4 is when cancer is spread outside of the bowel to other areas of the body, and those patients are often receive drug treatment like chemotherapy as well as other treatments in combination. On the blood tests, we can check for common things that will go out of range if a patient's cancer is being active. And there's one particular thing, a tumour marker called CEA, which is a protein in the bloodstream which we can detect. And for some bowel cancer patients, that can be useful for monitoring the response to treatment like chemotherapy, and also for monitoring patients after treatment to see if their cancer has recurred. There are clinical trials running all the time across the world looking at new drug treatments for cancer and new combinations. So we have a number of different chemotherapy drugs we can use for bowel cancer, either on their own or in combination. And so we use different drugs in different situations for patients. And we can also adjust the dose based on how fit and well a person is, how their blood tests look in terms of their kidney and their liver function.
Like all areas of medicine, the treatment of bowel cancer relies on the constant support and attention of specialist nurses, including the stoma nurse. But what exactly is a stoma?
It's essentially a portion of bowel that we bring to the surface of the tummy wall, so that patients don't have to go to the toilet to open their bowels normally, but the waste comes out into a bag that sticks onto the tummy wall.
We always start off in hospital with just, a kind of bog standard bag really. It's just a drainable bag which can be sealed up at the bottom. And then a hole is cut at the back for the size of the stoma, because obviously everybody's bowels are different size. And when stomas are formed, they can be a lot bigger than they eventually end up as. So stomas do shrink like anything, they shrink in time, and then the hole gets adjusted to the size of the stoma.
Do you custom fit it at all?
Yes, so we can, for lots of people, their dexterity may not be very good and they're not comfortable cutting bags. Eventually stomas will shrink to a size that they more or less stay at, and we have companies that will cut the bags, so when the patients receive their products at home, they open them up and they're cut to the size of their stoma, so it's just easier for them to fit. There are lots of other little things, there are lots of accessories. There's not just a bag, there are other accessories that we use sometimes depending on the stoma, depending on, the output, depending on the patient. So we've got a cupboard just full of stoma supplies, and obviously this room is where we normally see patients, is also equipped with lots of different supplies that we use to try and obviously solve any problems that we might encounter while patients have got their stomas.
Do you mark the body?
Yes, we do. So we see patients for planned surgery, normally a good 2 weeks before their surgery. So we've got plenty of time to be able to explain to them about what life with the stoma is going to be like. We bring them in here with any family members that want to come with them. We show them the stoma appliances, we show them pictures of stomas. We mark their tummy in agreement with them to the best position to where that stoma should be for them. So depending on where they wear their clothes, avoiding any natural creases on their abdomens. And then we also give them little trainer packs to go home with. So they go home with some stoma bags, little pretend stoma, which they can stick onto their abdomen, and then they can fill it with fluid, and so they know what it feels like to go home wearing a stoma, and they can practice at home. And then when they come into hospital, it's not such a big shock to them. A lot of people are frightened of stomas, and I think some of that is learnt behaviour from what we've heard from other people. So in the past, people have said, oh, somebody had a stoma 20 years ago and they had nothing but problems with it and it leaked. And I always encourage patients that nobody should have to suffer with a leaking stoma bag or be worried about it. They have to come back and see us. We keep regular contact with our patients initially if they've had surgery. If they've got any problems, they ring us and come back here and see us.
How often do you have to change a stoma bag?
So if it's from a stoma which is a colostomy, which is on the left-hand side, it's normally a very normal bowel motion. So it's like we would go to the toilet and we have a normal sort of formed bowel motion. So not everybody gets that. So it may be just depending on how often you open your bowels. It may be once a day, it may be twice a day. Very rarely, sometimes 3 times a day, because the output's so thick, it goes into a bag that looks like this, except it's closed. All right, so they wear it like that, it's a closed bottom. So when the bag's full, they take it off and put another bag back on. When it's on the right-hand side and it's an ileostomy, because it's small bowel content, the output is much looser. So they are able to drain the bag from the bottom, and they can leave a bag on up to 3 days. Some people choose to change it every day, some people choose it every other day. But we say 2 to 3 days is quite normal to wear a drainable bag, and then you take it off, obviously, discard it and, get another bag.
And are stomas reversible?
A lot of stomas are reversible, and the amount of time depends on how well the patient recovers from surgery. So some patients, patients are very keen to get their stomas reversed. So it depends. Sometimes it can be at least 6 months, it can be longer. Some people choose not to have their stomas reversed. They realise that actually when they've had it done, life isn't that bad and they don't want to put themselves through another big operation. So, depending on age and dexterity and their quality of life, if they think their quality of life is fine, they've been through a big operation, they don't want to go back. Obviously, as many stomas as reversed, we get new patients coming in that need to have stomas. So we're more, if patients want it reversed, obviously they go onto waiting list and have it reversed as soon as possible.
What about water?
Well, the bags are so advanced these days that they all have little filters built into them that you can see here. So the bags are completely waterproof. Lots of people swim in them, they bath in them and they shower in them. We advise them to keep their bags on while they do that, but you should be able to return to a normal life, still being able to, shower, swim, bath, anything that you want to do with the stoma bag. Any kind of physical activity, you can continue your life as normal as you did before, obviously after you've recovered from your surgery. So we advise patients to wait a good 3 months before they start, doing anything too physical, and then gradually build their sort of exercise levels up until they feel comfortable, and eventually they'll return to their normal, levels of activity they did beforehand.
Does the port get sore?
The stoma area is sore. To begin with, it's stitched. The stitches dissolve after 3 or 4 weeks. We use a special little stoma powder around that area to begin with. As long as the bag fits well, the size is cut to the right size, there's no reason why anybody should have to experience soreness or irritation with stomas. Obviously, like I said before, we've got lots of different bags, so if they have reactions or skin reactions to it, which anybody can get, we can change the bag. They can come in and see us, we can trial different things until we find the solution to the problem, and that is our job to do that.
Do some patients become so comfortable with it that they forget it's there?
I think, lots of patients say that to us. They say, there was a massive fear having it, and now I'm just getting on with my life as normal. And it's great when you see people come back into clinic maybe 3 to 6 months after surgery. they're not obviously in their hospital attire anymore, they're dressed and they look just like they did when we saw them pre-op. You know, so they've got back to their normal lives and they have forgotten that their stoma's there and they're living their lives to the optimum that they can at that time.
Another key role is a specialist colorectal nurse. Kerry Martin is at the Royal Devon and Exeter Hospital.
So depending on which route that a patient comes in for their diagnosis, they can either come from a GP referral or they're seen in a clinic. They will then have their diagnostic procedures, so colonoscopy, CT scans, MRI scans. At that point we get involved. They go to our multidisciplinary team meeting.
A multidisciplinary team meeting is a meeting where we discuss all of our patients who are affected with bowel cancer on a weekly basis, and we discuss between 30 and 40 patients per week. And we're looking at all of the key pieces of information about that patient, including the results from their radiology, so CT scan, MRI scan, their colonoscopy, and any biopsies that have been taken. In that meeting, there are surgeons, there are radiologists, there are oncologists who deal with chemotherapy and radiotherapy, and all of the specialist nurses that run the service with us. And what we're aiming to do is to use all of that information with all of those key workers to come up with the most appropriate treatment plan for the patients who are diagnosed with bowel cancer and who are undergoing treatment for bowel cancer.
How challenging is it to support patients at such a critical time?
Challenging in that it's managing their expectations of and timescale of how quickly things will be managed and done. But also it's important for us that we look at them in a holistic sense, that actually it's often the families or friends that it impacts on as well. So it's managing that.
My name's Neil Smart. I'm a consultant colorectal surgeon here at the Royal Devon and Exeter Hospital. I'm also an associate professor of surgery at the University of Exeter Medical School. And my role is that I do the operations that hopefully cure the cancer. So the two main ways of tackling an operation are either through keyhole surgery, also known as laparoscopic, and open surgery, which involves big cuts on the tummy. We can take out segments of bowel, either the right hand side or the left hand side of the bowel or the rectum, or occasionally you have to take out more than one bit, and sometimes we have to take out all the large bowel. For some patients, their quality of life after an operation can be improved because they no longer have the symptoms that they were having beforehand, particularly if they were troubled by problems with diarrhea or with pain or pain after eating and weight loss and lack of energy and the low blood count or anemia that can sometimes come with having bowel cancer. So for many patients, things can be better than it was for the preceding few months. But sometimes patients can have problems with their quality of life after an operation, which can come about due to complications that they suffer. And there are many different ways in which that can affect them. Although cancer of the bowel is most common in patients as they get older, there are certain groups who can get cancer at an earlier stage, particularly those who've got certain types of genetic syndrome.
Some people are more predisposed to colorectal cancers. There are genetic syndromes like FAP or Lynch syndrome. So these are genetic mutations that are normally passed on by your parents that mean you're at higher risk of developing polyps. And patients who have lots of polyps, some people can have hundreds of them, it does increase your risk of developing a colorectal cancer. About a third of cancers have some sort of family history, and that means that there are probably small genetic changes that have developed that increase your risk of developing cancers. And part of our research is trying to look at those unique changes in DNA.
Back at Derriford Hospital, I asked Mark Coleman what the national statistics were for bowel cancer.
Approximately 30,000 people per year are diagnosed with bowel cancer. And that is the second most common cancer in men and women, but if you put them all together it's about third or fourth because of the incidence of lung cancer.
How curable is bowel cancer?
So if caught early enough, bowel cancer can be cured with really good rates of success just with surgery alone. Some patients sometimes need additional treatment with chemotherapy, and in certain circumstances, patients with rectal cancer will need treatment with a combination of chemotherapy and radiotherapy. I think certainly as we've progressed over the years, better quality surgery has led to better quality outcomes. Changes in terms of how we give chemotherapy and radiotherapy to patients has also led to improvement in patient outcomes.
The producer of this video had bowel cancer a few years ago. Tim, it can be a really difficult subject to talk about, but when did you first know that something wasn't quite right with you?
Well, I'm probably one of the exceptions. I didn't know. I'd had a history of ulcerative colitis since I was really quite young, 20s. And when I reached the age of 60, because I'd had ulcerative colitis and had bleeding from the rectum and mucus and all the sort of normal ulcerative colitis signs, the hospitals call you in about once every 12 months and give you a colonoscopy, which, as we know, is the camera up the bottom. And I actually got quite used to this, and so after a while, every time I could look at the pictures on the monitor and think, oh, well, it looks okay, pretty pink. But we used to joke about things as the camera was going up and down. And then about 5 years ago, the same doctor I'd normally had this operation with, or this procedure, suddenly stopped talking, and I looked at the screen and said, what's the matter? And he said, oh, I'm afraid I found cancer. Well, it was one of the most extraordinary ways to discover you've got bowel cancer.
And how did you feel when you found that out?
I was actually devastated. I didn't really know what to say, because obviously there was no announcement as to how bad it was, which stage it had reached. He came and saw me afterwards in the recovery room and said, don't you worry, everything will be fine, we'll put you on the right course. And I got led to one of the surgeons here, colorectal surgeons here in Derriford, and he was brilliant, and he talked to me and he said, I think you've not got it too badly. It's you might not have to have a stoma, but I won't know until I get in there. And he went in there and he removed most of my colon, but not the last part, so I didn't have to have a stoma bag.
You're making that journey from diagnosis to having the operation sound incredibly simple. How quick was the whole process?
I think it was pretty quick. They have these multidisciplinary meetings where they sit down all the people involved in your case. So if you've had a colonoscopy, he will meet with the surgeon and with the cancer nurse, and they'll discuss your case. And by that time I'd probably had blood samples, and they could work out how far, oh, of course they'd sent away the tissues, the little snippets from inside to see how far the cancer had got. And I think if I had been quite seriously down the path of the cancer having spread, I probably would have been operated on much quicker. But I think it was about 8 weeks later that I had the operation.
But there was plenty of support along the way.
Yes. You meet the nurses, and the nurses tell you what to do and what to eat and how to prepare for the operation. I don't remember much about the operation, naturally enough, but when I came to, I know that was pretty nasty, the recovery in the ward. But I was only in the ward about 3 or 4 days and was let home. But of course I had a scar from here to here, so I had to look after that. But in remarkably quick time, I was out playing golf, sailing and doing all the things I normally do.
So apart from the scar that you have, what are you living with now?
Really, I think the expression is cured. It's not even a remission. They've actually cut the whole of the bowel out, which was infected with cancer. And unless it comes back, I'm not sure how it could. It might come back on the last bit of my colon, the rectum. But I'm out playing golf, I'm sailing, I'm doing all the normal pursuits that I used to do.
You're talking about this like it's very matter of fact, but for some people who think there's something not quite right, it's a very difficult thing to talk about. What would you say to someone who maybe is concerned about something?
I'd echo all the advice we've been seeing in this video, and I would get to the doctor as quickly as possible, because the sooner they find this disease, the better the chances are that you will be cured.
And there is life after bowel cancer.
There is certainly life after it. I obviously feel sorry for people who have left it too late and have gone to the stage where you get involved in chemotherapy and radiology. I was very lucky. I didn't have to have that, but some people have had to, and that's not the end of the line. I mean, that is, as you will see in this video, the advice from the oncologists and the science and the nature of things is improving so much that they're really getting on top of it now.
So we're at Derriford Hospital, which is the largest single hospital in the whole of the Southwest, and we see over 250 patients a year with bowel cancer here. And this charity, Bowel Cancer West, has spent probably, in terms of all of its projects in Derriford, more than £250,000 over the last 10 years. We are in a patient room which was redecorated and provisioned by Bowel Cancer West with a grant, and this is the area where we bring patients to often break bad news and bring their relatives as well, and it's used by our cancer nurses, our doctors and other healthcare professionals. We raise money from all different sources, and all of our donors and fundraisers are of equal value. At one end of the scale, at the top end, we've had huge donations from wealthy individuals and companies, and we've also had donations, small donations from many different individuals raising money or donating money off their own back because their lives in some way have been touched by bowel cancer. We have supported a variety of different projects over the years concerning awareness, research and training, particularly areas like genetics, because a proportion of patients who have bowel cancer, it's inherited from their parents, and understanding why that happens and what we can do to change things is very important. Also, the one area where bowel cancer is increasing in terms of incidence and diagnosis is in young patients. And we want to understand that and support patients better who are younger that are diagnosed with bowel cancer. And we're also looking at the fitness of patients approaching surgery for bowel cancer, because the majority of patients with bowel cancer are quite elderly. And of course, some of them have heart disease and diabetes and other problems, and making them as fit as they can before surgery helps us to give them a safer, better treatment and a longer, better term outcome.
With modern surgical techniques, patients recover quicker from surgery with fewer complications, and that has to be a good thing.
What are your hopes for the future?
Our hopes are to grow as a charity to the effect that we can support more projects and help more patients and their families who are touched by this disease.
If you have bowel symptoms that don't settle, see your GP early, don't just sit on it.